video. Namaskar. Good evening, all dear friends, seniors, and teachers. I cordially invite you for this 28th API DIAS program today. Today is little special than our routine API DIAS programs, which we conducted all through the year. Today, it is going to be a launch of RSSDI guidelines with respect to thyroid disorders treatment and management or screening of thyroid disorders. That's going to be something special in collaboration with RSSDI national body. So I am Dr. L. Srinivas Murthy from Bangalore, consultant physician and diabetologist. So let us move on to the program. As I said, today it's going to be special because we have an international speaker who's going to talk about subclinical hypothyroidism, what's new in that, and what is the management strategies. And coming to our Indian context, we are going to talk about the RSSDA guidelines and how do we proceed further. Now, I respectfully invite our president of API, Dr. Arul Raj sir, to come on to the dais, please. I invite Dr. Shashank Joshi sir, who's the Dean of ICP, Indian College of Physicians, to be on the dais. I invite Dr. Mangesh Tiwaskar, our Secretary API, to be on the dais, please. And Mr. Anil Joseph, Managing Director, About India, to be on the dais, please. So as I said, today's API DIAS is a very special one, though it's a 28th one. We know that the API DIAS was started way back in 2013 and 14 by Dr. A. Muruganathan as a physical CME events. Until the last version of API DIAS, the event has seen participation of more than 18,000 physicians across India. However, last year, thanks to pandemic COVID, that the event went virtual, and the blessing in disguise that we saw a record-breaking participation of up to 70,000 physicians, not only in India, but it went on virtually and globally as well. So let us look at a small audio-visual clip on API's journey that we have this AV for all of you to witness the journey of API since its inception, and let's see how we have transitioned from a physical CME to a virtual successful CME event. AV, please.
My dear brothers and sisters, first time with the help of Abbott Healthcare, we have started this live CME in 33 cities, which will cover at least 3,000 physicians and 13 hours of learning.
On behalf of the Association of Physicians of India, I take this opportunity for coming here to listen, learn and adapt.
Welcome you all to the API DIAS program. This year, we plan to spread the program to about 50 cities and reach out to more than 6,000 physicians.
Esteemed API member and my colleague, I have a proud privilege to welcome you all to API DIAS, a scientific platform, in 2017. It is my proud privilege to announce that API DIAS has reached over 11,000 physicians in 50 major cities, in second largest platform after Epicon.
Let me welcome you to the API DIAS 4th edition. These programs, we have decided to make this platform as a virtual program.
Thank you. That was a small AV clipping where we saw the journey of API DIAS from physical to virtual, how it has reached out to the 70,000 plus physicians across India and worldwide. So it's our privilege and honor to welcome our chief guest of the day, Dr. Dilip Maheshekar, to the DIAS, please. Sir is the Vice Chancellor of Maharashtra University of Health Sciences. So before we go further, I request all the delegates to register your details so that you get 1 credit point from Maharashtra Medical Council for participation in today's CME event. So kindly register with all your details. Now let's move on. I request Dr. Arul Raj, our Honorable President for API, to come onto the dais and give his presidential address. As we know, Dr. Arul Raj is an adjunct professor of medicine at the MGR Medical University, Chennai in Tamil Nadu. He's an honorary national professor of medicine in IMA, CGP India and IMA India. He's a fellow of Royal College of London and Glasgow, and is a founder and past chairman of Commonwealth Professional Alliance, UK. He is the past president of Commonwealth Medical Association, past national president of IMA India also. Sir is a gold medalist in MD, and he's done a lot of work in the preventive cardiology in the rural segment in our country. Over to you, sir.
Good evening to all of you. Thank you, Dr. Srinivasa Murthy, for the nice words said about me. I'm so happy the way in which you are steering today's, API DIAS in a very, very, very positive direction. It's a need. And my sincere thanks and welcome our Honorable Chief of today's evening, Dr. Dilip Maheshekar, the Honorable Vice Chancellor of Maharashtra University of Health Sciences, for sparing his time and being with us today. Now, friends, API is science. API always supports science, and API grows science. That is well known. This is a statement I always make about API. Being involved in, many national organizations, I have given the slot for science for API. And in that venture, in whatever way the knowledge and skills of the physicians could be updated, API is trying its best. And the end result, one of the end results is API DIAS. As you saw in this AV, in 2013, this program was started. That time it was a physical program from, states to states and branches to branches it went, thanks to the uncentered support by Abbott's, India. And we reached to about 50 cities around, 24,000 physicians of this great nation. And thanks to Abbott and all our past presidents of API. This corona has done a lot of damage, lot of negatives, but one positive is that it has pushed us to go digitally. I mean, both for treatment as well as for learning. Now we are on this digital mode in different parts of this, I mean, great nation. We are able to share our knowledge. This is advantage. This is formation of API DIAS digitally, reaching the unreached. Now we, agreed for 30 programs. Today is the 29th programs. Thanks to again Abbott and its managing director, Mr. Anil Joseph. We have extended it by another 15 programs. Why? This digital program has no boundaries inside the country. And now for the past 6 programs, we have exceeded the boundaries of India too. We have gone into South Asia region. We are now going into the Middle East, and slowly, by the time when the 45th program is over, we will always be global. We have Indian physicians globally. Sure, we will be able to interact and share the knowledge and expertise. And regarding the, today's program, all of us are aware, it is an excellent topic that we have chosen today. Something related to thyroid dysfunction. The word subclinical hypothyroidism has lot of meaning inside. I used to teach the young, my postgraduates, that today, earlier days, when we were all students in 1960s, we used to be told by our teachers, you know syphilis, you know medicine. After that, when we came to nearly the 19th century, rather 20th century, it used to be taught, you know diabetes, you know, medicine. That is how all senior, diabetologists and physicians said. In 21st century, the statement will be, you know thyroid, you will know medicine. Because thyroid is not a single endocrine disease. It is a, systemic disease with greater effects on cardiovascular system. Actually, API has brought out a lot of documents on, the cardiovascular effects of hypothyroidism, hyperthyroidism, subclinical hypothyroidism, low T3 syndrome, and whatnot. And actually, one book is under editing. I am sure this program also, lot of inputs will be taken up from the international and national faculties. And I am thankful to RSSDA for joining its hands with API and bringing out its, the guidelines, which will be a landmark, occasion in the academics of, thyroid dysfunction and systemic illness. And I am so sure all the members who are participating, will get updated in their knowledge and skill so that best care can be offered to their needy citizen. I wish this seminar, API DIAS, very great success. Thank you all very much. Thank you very much.
Thank you, sir. Thank you for your kind words and enlightening us about the API DIAS and the background for setting it virtually also. Now I request Professor Dr. Shashank Joshi, sir, to give a Dean's address. I'm sure, ladies and gentlemen, you know Dr. Shashank Joshi, sir, who's Chair of IDF Southeast Asia Region 2021, Dean of the Indian College of Physicians currently, and you know his work. I don't think you require any introduction to him, but it's my privilege and honor to introduce him, though in few words, that he is a fellow of several medical societies, including the American College of Endocrinology, American College of Physicians, the Royal College of Physicians and Surgeons, and Royal College of Physicians as well. He has published more than 100 books and monograms and over 800 research publications, and has been the editor of various Indian medical journals, including our JAPI and Indian Journal of Critical Care Medicine, which he founded. And he has received more than about 200 awards, and he is awarded the International Clinician of the Year, awarded by the American College of Endocrinology in 2012, and is received Padma Shri by Government of India in 2014. And his work not only limits to the endocrinology, but we saw in the COVID era, he was one of the key task force member in the Maharashtra task force for controlling the COVID infection. Over to you, sir.
You see, it gives me a great pleasure that the academic wing of API is the Indian College of Physicians, and Dr. Arul Raj has taken and continued this API DIAS program, which used to be a physical program, which used to go to almost 80, 90 cities, towns, and parts of India to do skill building, capacity building. He has converted this whole knowledge dissemination exercise into a digital platform. The two main thrust areas which I want to talk is, one is the telehealth and telemedicine, which he very nicely said that today is the era to adapt and learn skills. We need to use technology right up to artificial intelligence in its best way. And second key is the patient to physician communication also is going to use the same telemedium. And therefore today the key is, the word is the tele. But at the same time, we should not get digitally intoxicated. And I always say in all my programs that you should do a 2 hour digital detox every day. At the onset, I really congratulate Dr. Arul Raj for wonderfully crafting this program, and my very close brother, Dr. Mangesh Tiwaskar, very astute Secretary General of Association of Physicians of India, with the help of our team Abbott. Let me tell you something about Team Abbott. They have virtually had no influence on this program. This is a completely unrestricted grant from them, and they have allowed us to take topics which are useful for the practicing physician and the clinicians, so that they can not only learn, but whatever they learn, they can adapt it into their day-to-day practices. And that is so critical and vital in today's times. Also, what is useful is that we need to recognize that healthcare is soon going to get digital, and it is going to become a interactive digital platform, and which is what we are using today. And that is something which is very, very pertinent in the today's era. We also would like to make an effort to capture your feedback and translate it. But the whole aim, as Dr. Arul Raj very nicely said, is that we need to ensure that what you listen, you learn, what you learn, you adapt. And I hope that the various pearls of wisdom in different domains of medicine, which will be spanned over this year, you will learn digitally. And actually this outreach, which Dr. Arul Raj said, is actually going to reach out to many more people. I was the second president to continue this API DIAS program, but we could reach a finite number. But now with digital health, we can not only reach within India, but outside India. And I would request everyone to make this program into a larger domain so that more and more people can listen, learn, and adapt.
Thank you, sir. Thank you for those kind words. And before we move on further, I request again delegates to register yourselves. You will get 1 credit point from Maharashtra Medical Council. And I welcome and thank Dr. Agamora, who is the observer for MMC today, for joining us. And let's move on. I request my good friend, now Dr. Mangesh Tiwaskar, who is Honorary General Secretary of API, to address the gathering. I am sure all of you are aware about Dr. Mangesh Tiwaskar, who's been editorial board on JAPI, Medicine Update, and IJD. He's been on the governing body West Zone representative of the ACP India chapter, and is a guest editor for Insulite Journal, World Journal of Anemia also. He's a gold medalist in his MBBS days as well, and is a great physician and diabetologist at Shilpa Medical Research Center in Mumbai. Over to you, Dr. Mangesh.
Guest, faculties, API governing body members, galaxies and friends. It gives me colossal pleasure and feeling of gratifying pride to say that with the efforts of our dynamic, ever-cognitive Technogat President, Dr. S. Arul Raj, we have kicked off one more session of API DIAS. We initiated the effort with physical one-day academic meetings, and then now we can successfully reach the truly unreachable through this digitalized revolution, which is now available to be used by all of us. I would express my momentous gratitude and thanks to the entire Abbott Healthcare and their very efficient, vibrant team for their unconditional philanthropic educational support to this academic extravaganza. I would request you to register each time before you join in, as Maharashtra Medical Council has been generous and very big-hearted enough to accredit this program with the credit hours. Thank you very much again for sparing your time and spending your precious period with all of us. I wish you a very happy learning. Long live API.
Thank you, Dr. Mangesh, for those words. Now it's my privilege and honor to introduce chief guest of the day, Professor Dilip Maheshekar. Sir is a MD in TB and chest medicine, and he's got a vast experience in teaching, research, and administration as well, all in one. And that's something which we as professionals lack in the administration section. But Sir has served as Dean and Professor and Head of Department of Pulmonary Medicine at Dr. Shankar Rao Chavan Government Medical College in Nanded, and is currently the Vice Chancellor of the Maharashtra University of Health Sciences. Sir, it's our honor to be inviting you onto the dais, and please give us a few words of wisdom.
Good evening. Thank you, Dr. Silraj and Dr. Mangesh Tivaskar and my friend Dr. Shashank Joshi. It's my proud privilege to share a dais on API. I would like to say two things: that I am the life member of API also, and my academic career started in the 1988 with the first my paper publication at API conference in AFMC. That is my first paper which has been started, and which has been accepted by the internationalization of the British BMJ. So that is the first credit goes to API, and after that I am the life member. I really thanks the API that they have invited me for this, though I was little bit got tagged somewhere. But it's really good that they are conducting this DIAS, academic DIAS for every faculty, and as well as because I have gone through this corona period. And I am always touched with Dr. Shashank Joshi. He is our chairman now. Dr. Srinivas Murthy now is the chairman of the state task force of the COVID for Maharashtra.
Okay.
Yeah. And really this COVID has taught us also, because you must have heard a lot of things about in Maharashtra regarding the medical colleges and other health sciences examination. But with all everything, as per the central guidelines of the government, all the faculties and all the councils also, we could make it success. Even only because of the virtual DIAS, so the number of faculties. Now, at the time it has COVID has taught us that we have to go virtually, and it is only because of this virtual platform I could join today also. And this has made a remarkable change in the era for as far as the doctor for exchanging the views and for the interaction with all the doctors in the faculty. I say that I know that the API will take it at least 2 more again in future also for getting the DIAS and academics fees to all the doctors all over the country. When I saw it was the member, there was something 4,000, it's like that, and today it is gone to 20,000, and it will go more and more. That's I wish. Once again, I congratulate for the organizers for this and academic fees for all the doctors and for inviting me for on this day. Thank you very much.
Thank you, sir. Thank you. Very kind of you, sir. And we always honor you. We are honored to be by your presence. Now let's move on. I'll request Mr. Anil Joseph, who is the Managing Director of About India, and to just briefly tell about him. He's worked in various divisions of About since 2016. Prior to that, he's worked in J&J family of companies in several business roles, including country director. And if you're drinking too much of Coke, he's the man behind who increased the sales, key accounts, and marketing strategies in the Coca-Cola India. He was a senior manager, marketing and key accounts for the largest region in the country. And he's got a prestigious Symbiosis Institute of Business Management in Pune. He's attended it, and where he received his master's in business administration. Over to you, Anil.
Thank you very much for that glowing introduction. I really appreciate it. Well, I'm just going to take a few minutes to talk a little about Abbott, the company that I represent. It's an absolute privilege and pleasure for us to be associated with API in such a wonderful forum, the API DIAS. It's been a true privilege to be able to extend any learning and to create this platform that can foster education and learning among such an esteemed group. Moving to the next slide, I just wanted to share that Abbott is a global health leader and one that helps people live life to the fullest at all stages of life. We have more than 100,000 people across the world and have been in business for more than 130 years. And it might be interesting to note that, we're one of just 52 companies from the original Fortune 500 and just 59 from the initial S&P 500 that remains on that list today. We're proud to serve people in more than 160 countries with a portfolio of life-changing technologies that span the whole spectrum of healthcare. We're the leading business and with products in medical devices, diagnostics, nutritionals, and branded generic medicines in emerging markets, and we generate sales of over $30 billion. On the next slide, I'm sharing again that our fundamental goal is helping people live fuller and healthier lives. We have a medical devices business that uses advanced technologies to keep hearts and arteries healthy. We treat chronic pain and movement disorders and give people with diabetes better insights, more freedom, and less pain. Our nutrition products build and maintain health from infancy onwards. Our diagnostics business provide information to guide effective treatment decisions, and our branded generic medicines help people in emerging markets to stay healthy. On the next slide, I wanted to share another fact, which is something that we're very proud of, and that is that, sorry, if you could move to the next slide. Oh, I think you might have moved a little too fast. Sure, thank you. So Abbott is number one in a various host of areas. We're number one in the remote heart failure monitoring, in stents, in transcatheter mitral valve repair, in heart pumps, continuous glucose monitoring, chronic pain devices, point of care testing, blood and plasma screening, and adult nutrition, pediatric nutrition in the United States, and in medicines across various disorders. This, of course, means that there's a huge responsibility on us to continue to deliver to our customers and patients across the world. On the next slide, I'll talk a little about our medical device business. And for years, this business has offered technologies that are faster, more effective, and less invasive. We're focusing today on personal technologies that empower people with the data and knowledge that they need to help them to live longer and to live better. Our connect, care, and digital health tools, which are so important in today's world, from mobile platforms to wireless implants and even wearable sensors now, they're helping people and their doctors make better, faster, and more informed decisions about their health in ways that easily fit into their lives. On the next slide, I'll talk about our diabetes care business. We are the world leader in continuous glucose monitoring. The new age, next generation sensing technology, the Freestyle Libre system is a life-changing innovation that offers the elimination of routine finger sticks to draw blood, actionable insights and improved outcomes, and a more affordable option compared to other continuous glucose monitors available today. Users of the Freestyle Libre can get a glucose reading and record the trends in their levels by just swiping an app-enabled smartphone over the Libre sensor. And it's now available in nearly 50 countries and reimbursed in more than 30. On the next slide, I'll talk about the business that I represent, the established pharmaceutical division. We're committed to bringing the benefits of these trusted medicines to more people in the world's fastest growing countries. And we offer a broad portfolio of high quality branded generic medicines across multiple therapeutic areas, which include gastroenterology, women's health, cardiometabolic, pain management, respiratory, and of course, very importantly, thyroid disease. This diverse portfolio includes the world's leading medicines for pancreatic enzyme deficiency, for progesterone hormone therapy, as well as vertigo. On the next slide, every day more than 18 million people around the world use our medicines. We differentiate ourselves from pure generic competitors in many ways. through our exacting quality standards, the reliable supply chain, superior clinical science, the product range, and patient-centered innovation. We also offer services such as A-Care, a first-of-its-kind digital platform that gives patients and healthcare providers tools, tips, and resources to better manage people's health. All of this is by offering market-specific portfolios that reflect the health needs of each region that we serve, with special emphasis in core therapeutic areas where there is unmet medical need. On the next slide, you'll see that we've 110 years of breakthrough health products in India, and that's a matter of great pride for us. We now have 3 manufacturing plants here, bringing products in to our patients and customers to the market much faster. And a dedicated innovation and development center supports our localized research requirements. Moving on, we've pioneered innovative ways to screen, diagnose, and monitor a vast range of health conditions. And you'll see that on the next slide, with greater speed, accuracy, and efficiency. And as a result, in immunoassay diagnostics, we've become a leading name. The same in blood screening, bedside testing, and companion diagnostics, with tests that provide information essential for the use of a corresponding medication or treatment. We're leaders in tests and instruments for hospitals, labs, blood banks, and clinics for general health screening, disease diagnosis, and monitoring. In fact, our blood screening systems and tests are used to safeguard more than 60% of the world's blood supply. Our molecular instruments and tests help to realize the promise of personalized medicine for managing infectious disease and serious illness. And patient-side blood testing for lab quality results are provided in minutes. Sophisticated information solutions that are so vital in today's world efficiently share information across the health system, enabling faster and better informed decisions about treatment. We've also become a leader in testing in the fight against COVID-19, developing multiple tests to detect the virus and antibodies to the virus. Just a few of the recognition that we've received are displayed on the next slide, where we've been named by Fortune as one of America's most admired companies every year since 1984. And if you could move to the next slide, you'd see some of the accolades that we've received. Now, this honor is a result of the excellence across our company. It's something that we take very seriously. We've been ranked as the industry group leader on the prestigious Dow Jones Sustainability Index for the 7th consecutive year, and it's a 15th year in a row that we've been named to this index. We've been named as Fortune's list of best big companies to work for in 2020. Something very special to us is also having been named as Diversity Incorporated top 50 companies for diversity for 16 straight years. These are just some of the recognition that we've reached and received across the world. But on the last slide, I just wanted to sum up by saying that we have been helping people live more fully for more than 130 years. And if you move to the last slide, I just wanted to mention that we value the achievement and perseverance it takes to accomplish challenging goals. This is the mindset that's reflected in our sponsorship of the Abbott World Marathon Majors, and it's evident in the way that all Abbott people approach the very important work that we do. We're very proud of our long history of success, but we're constantly looking to the future, seeking new and better ways to help people live their best and fullest lives. We are strong, we are focused, and we are very ready for the future. Thank you for this opportunity, and I hope everyone enjoys this session of learning.
Thank you, Mr. Anil, for this brief journey about India, and we really appreciate on behalf of API your unrestricted educational grant to bring up this API DIAS to reach out to as many physicians as possible. Thank you very much again. And ladies and gentlemen, let's move on to the scientific session. That was the inaugural session. Now we have got a great scientific feast for you waiting ahead, starting from now. And the focus of today's topic is about thyroid. We have newer updates in subclinical hypothyroidism to begin with. Later on, we have RSSDA guidelines of 2021 recommendations on thyroid disorders. Will be spoken by Dr. Rakesh Sai, Dr. Krishna Sheshadri, Dr. Sujay Ghosh, who are all great speakers, one of the cream people in our country with respect to the orations, and will be moderated by Dr. Sanjay Agarwal. And now let's move on to the first topic in the scientific session, which is newer updates in subclinical hypothyroidism. I'm sure all of us face a lot of problems to diagnose and treat the subclinical hypothyroidism. So let us look at the newer updates. And to talk on this, we have our friend from overseas, Dr. Salman Razvi, who has joined us from UK. He is a senior clinical lecturer and honorary consultant endocrinologist from Newcastle University, UK. He is executive committee member of the British Thyroid Association, member of the Northern Endocrine Specialty Training Committee, Health Education Northeast, and he is a medical advisor to the British Thyroid Foundation. I think he's the most capable person who can talk about the recent updates on the subclinical hypothyroidism. Over to you, sir.
Right, thank you very much. Thank you very much for the kind invitation. It's a great honor and pleasure to be there amongst you. So good evening to everyone. I'll start with sharing my screen. Perfect. So first of all, Professor Maishekar, Professor Arul Raj, Professor and friend Shashank Joshi, Dr. Murthy, and Mr. Joseph, and everyone of you. It's very kind of you for the kind invitation, and hopefully it's also a challenge to try and fill in a vast topic within 20 minutes. But I'll try and do my best. So first of all, the disclosure, I received speaker fees from a few companies, but that hasn't and shouldn't influence my views or my interpretation of the scientific literature. So first of all, how do we define subclinical hypothyroidism? It's diagnosed basically on biochemical grounds when TSH levels are elevated, but thyroid hormone levels and mainly T4 levels are within the reference range. The reason why TSH is checked first is because it's considered to be a very sensitive biomarker of an individual's thyroid status. And the reason why that is because for every 2-fold change in free T4 levels, there's a 100-fold change in TSH secretion. And this is better represented here, where you can see on the x-axis the free T4 range and on the y-axis the TSH range. And as you'll see here, for a 2-fold change, either an increase or a decrease, you'll see a corresponding inverse relationship with TSH. So if free T4 levels increase by twice the number, then you'll see 100 times reduction in TSH, and vice versa. So if there's a halving of free T4 levels, then you will see 100 times increase in TSH levels. And therefore, over the years, since at least when TSH became available in the late 1960s, it's become very easier or much easier to diagnose subclinical thyroid disease. And as the TSH assays have improved, so has the sensitivity to diagnose even milder forms of thyroid disease. And therefore, the current view is that subclinical hypothyroidism itself should be graded into 2 criteria or categories. Grade 1 is where the TSH is just above the reference range but below 10, and grade 2 when it is greater than 10. And there's a slight difference between the two and how we deal with this, and I'll come back to that as we progress further in this talk. Now, the other thing which I think is crucial and not necessarily for thyroid disease, although it's an important part of it, is associations do not always mean causation. And the reason why I say this is because on your screen, you'll see ladies from a mountainous region who all have got goiters and fairly dramatic goiters as such. And if you were to do epidemiological assessments, you would notice that the prevalence of goiter increases as per the altitude of the person where they live. So if you look at altitude, and as the altitude goes up, the prevalence of goiter goes up, and so the people would think that altitude causes goiter. Whereas we know that that isn't the case. It's actually related to iodine intake, because altitude is related to iodine. The higher we go away from the sea, the less iodine there is in our diet, and that low iodine then leads to goiter formation. So without thinking of the intermediaries and the other factors that might account for relationships, we cannot just always assume that association always is causation. Certain things are related to causal factors, but not always the case. So some of the associations of subclinical hypothyroidism, and these are some of the reasons why we might want to think of treating our patients, is related to symptoms and impaired quality of life, reduced cognition and dementia in older people, a higher cardiovascular disease burden in this group, the risk of progression to overt disease, and in pregnancy especially, the risk of miscarriage and the risk that the offspring's IQ might be lower than otherwise it would have been. So let's take some of these things turn by turn. So this study from Colorado in 2000 looked at tens of thousands of people who were attending a health fair, and they looked at the prevalence of symptoms related to thyroid disease, and they then correlated that with their blood test result and found that some of the symptoms of thyroid disease were certainly much higher in people with an elevated TSH. But if you look at this, it isn't by itself a discriminatory factor. So it's not as if some of these symptoms are present in 100% or a 90% or 80% of people with thyroid disease and 0 or 5% of people with normal thyroid function. There's a difference, but by itself, it will not let you diagnose thyroid disease. For example, one of the most common symptoms that a lot of people have with thyroid disease is feeling tired. And as you'll see here, roughly 20% or slightly less than 20% of people with subclinical hypothyroidism report tiredness, and 15% of people with normal thyroid function also report tiredness. So that by itself isn't necessarily a discriminatory factor, but taken together, that might account for some of these things. So I think what it tells us is this should act as a screening test, and if people report symptoms, then a check of thyroid function should be made. So does treatment improve symptoms in people with subclinical hypothyroidism? We haven't got a lot of randomized controlled trials in this area. The most recent and largest study was the TRUST trial, and this was done in older people above the age of 65 across 7 or 8 European countries. And they looked at 2,647 people who were screened, and eventually 737 people were randomized. The original idea of this group was to assess for cardiovascular disease, but they could not recruit at a fast enough rate, and therefore they settled for quality of life as the primary outcome. And they treated half of these people with levothyroxine, and you'll see on the right-hand side of your screen that in the levothyroxine treated group, the TSH levels reduced from about 6 down to about 3.2 or 3.3. And in the placebo-treated group, there was a slight reduction, but it was still higher than 5 at the end of 12 to 18 months of follow-up. And lots of results from this trial, but I've highlighted the p-values in the most important primary outcomes that they looked at, which is the hypothyroid symptom score and the tiredness score. And at 12 months and at 18 months, there wasn't a significant improvement in either of these scores in this older group. What about much older people, 80 years or more? Now, this is a combination of a subgroup from the TRUST trial that were older than 80 and another trial from the Netherlands called EMO, and they combined these two trials together and recruited people above the age of 80 and randomized 90 people to thyroxine and 122 to placebo, followed them up for 12 months. And you'll see that again, the hypothyroid symptom score and neither the thyroid score improved substantially in the group treated with levothyroxine. And once again, suggests that thyroxine treatment doesn't really improve symptoms in much older or even slightly older people. What about younger people? There does seem to be some benefit. So this was a study that I was involved with a few years ago now. And when we looked at overall quality of life in this group, which was predominantly younger people in the 20s, 30s, and 40s, their motivation, their overall symptoms and quality of life, there was borderline improvement. But the reason why this was borderline is because we assessed so many things, we had to adjust our p-value accordingly, and therefore it was quite stringent, and we realized that 100 patients weren't enough. If we had 150 or 200, then this would have been significantly better. But again, suggesting that there might be an age difference between the treatment parameters for subclinical hypothyroidism. So why is there a difference in younger versus older people? Well, one of the problems may be that symptoms are so non-specific that they might be unrelated to thyroid disease. It is possible that as one gets older, a lot of these symptoms, non-specific symptoms, become more common. It may also be that higher TSH levels in older people are physiological, and there's a lot of evidence for this, and this is getting stronger and stronger each passing year. The TSH level in a lot of these patients may have been transiently elevated, and we can see that in the placebo-treated groups in a lot of these trials, that the TSH levels always tends to reduce somewhat. It doesn't reduce down to normal, but it does reduce. It doesn't. I've never ever seen it going up in the placebo-treated group in these patients. The other thing that is also important to highlight is that the vast majority, in fact, all of these trials did not specifically recruit patients with grade 2 subclinical hypothyroidism. And grade 2, if you remember, is when the TSH level is greater than 10. So this was the enhanced trial study survey in the US, which was the first one to suggest that TSH levels actually shift to the right, meaning become higher as one gets older. What about cognitive function? Again, another study, this time from Birmingham here in the UK, looked at older people above the age of 65 with subclinical hypothyroidism. And over a period of time after treatment, neither the depression score nor the cognition score improved. And you'll see the highlighted p-values on the right-hand side of your screen, suggesting that treatment, again, in this slightly older group of people doesn't really improve markers of depression or cognition. Now, there's a lot of talk about the cardiovascular association of subclinical hypothyroidism. And again, a lot of this comes from observational studies. The Rotterdam study in the year 2000 suggested that there was at least a 2-fold increase in the age-adjusted relative risk in women above the age of 55 years in MI, in women with subclinical hypothyroidism. And another study that we did here in the northeast of England called the Wickham follow-up, where we looked at the Wickham cohort and found that the subclinical hypothyroid group had a higher risk of developing ischemic heart disease when followed up for over 20 years. Subsequent to that, we contributed to a large meta-analysis of greater than 55,000 participants across 11 studies that had 9,000 and more deaths, of which 2,000 or more were from coronary heart disease. And subclinical hypothyroidism in this meta-analysis was defined as TSH between 4.5 up to slightly less than 20 milliunits per liter with normal free T4 levels. And what was found in this analysis is that the association with coronary heart disease events and mortality was much higher as the TSH levels became higher than 10, certainly, and CHD mortality more than 7, certainly. And again, I stress these are associations, doesn't necessarily imply causation. We need randomized controlled trials to show this. And as we've seen from the TRUST experience, these are difficult trials to perform. You'll see the P for trend for the changes in TSH levels. So as TSH levels goes higher, the risk of both coronary heart disease events and mortality becomes higher. So does treatment improve cardiovascular risk factor profile? Well, we do see a modest reduction in LDL cholesterol in subclinical hypothyroid people. There's an improvement in endothelial function. There is reduction in carotid intima media thickness in younger people, but not in older patients. And we've seen this from a study in Italy. We've seen this from the subgroup analysis of the TRUST trial, that there does again seem to be a age differential here. There is no great effect on blood pressure, and there is no significant effect on weight. Despite a lot of people getting their thyroid function checked because of concerns of weight, if you treat people with subclinical hypothyroidism, the consensus is that at most, you'll probably reduce their weight by 1 or 2 kilograms, if that. And in somebody with a weight of 90, 100 plus kilos, 1 or 2 kilograms isn't really going to make a huge difference to their cardiovascular risk profile. Now, what about people at high risk of developing further cardiovascular disease? So if you take people with, and there could be no higher risk group than patients with acute myocardial infarction, and there have been some previous studies from PISA in Italy that has suggested that people with subclinical hypothyroidism at the time of MI have a much higher risk of further cardiovascular mortality. And that's the reason why we did this study here in the northeast of England, where we randomized half the patients with subclinical hypothyroidism at the time of their MI to levothyroxine and the other half to placebo, and followed them up for 12 months. And we were looking at the left ventricular ejection fraction using cardiac MR, which, as I'm sure a lot of you are aware, is one of the most reliable markers of cardiac function. So the key points of that trial, which was only published a few months ago, is that there was no significant improvement in the left ventricular ejection fraction of the treated group versus the non-treated group. And so what this means is that it doesn't support the treatment of subclinical hypothyroid in patients with acute MI. There are some subgroups within this that it did seem to have an impact on, but and those were patients with reduced ejection fraction to start with, but this was a relatively small trial, so therefore you can't read too much into subgroup analysis in this paper, and therefore we'll probably need to do much larger focused trials in those specific groups of patients. So as far as cardiovascular disease is concerned, there is an association with higher cardiovascular risk when TSH is greater than 10. It may be associated with higher cardiovascular risk in younger people. Very modest improvement in cardiovascular risk factors or surrogate markers in treatment groups, and higher TSH in older people may not be detrimental and may even be beneficial. And this has been shown in some studies, including from Leiden and also here in Newcastle. What about progression to overt hypothyroidism? The risk is dependent on the level of TSH, the risk being much higher when TSH is greater than 10. In people with TPO antibody positive, the risk is higher. The rate of progression is variable and could take many years for some and could never progress in some others, and has to be balanced with the risk of spontaneous normalization of TSH in also in significant proportion. And a lot of trials, and again, I just quote one trial here, which has shown in the placebo-treated group from the Birmingham trial that roughly 50% of people at 12 months actually normalized their thyroid function, who had subclinical hypothyroidism with a TSH of 6.65 to start with. So this is something we have to bear in mind, that not everyone progresses. So that's the reason why when we were drafting the European Thyroid Association guidelines on the management of subclinical hypothyroidism, we came out with this, that the age of the person and the level of TSH increase has to be borne in mind. And if the person is age less than 70 and the TSH greater than 10, they should be treated. If they're less than 10, if they do have hypothyroid symptoms, and if it's consistent over a period of time, then a trial of treatment should be given. Whereas in older people, if the TSH is less than 10, they should not be treated. If the TSH is greater than 10, then an individual person response should be made. So individualized treatment, basically. What about other recent recommendations? Some people have taken this even further. So in the BMJ a couple of years ago, this clinical practice guideline was published, which came out with this very strong recommendation against thyroid hormone therapy for patients with subclinical hypothyroidism. This was a kind of a blanket recommendation, which a lot of other people, including myself, don't really agree with, because it says that anyone, irrespective of age, irrespective of the level of TSH, irrespective of symptoms, shouldn't be treated with levothyroxine up to the level of 20. So the evidence base for the level of 20 is rather sketchy, but I just bring it here to highlight there's variation in practice and in views across the world. So again, observational studies have suggested that higher TSH in pregnant women has been associated with lower IQ in the offspring. But again, two trials. One, it was a CATS trial from Cardiff here in the UK by John Lazarus and company, did not suggest any benefit of treatment in the IQ of the offspring when treated. And another trial, which was done by Brian Casey in the US, did not show any improvement in the rate of miscarriage or stillbirth or neonatal death in treatment in this group. And I go back to this study, observational study by Peter Taylor, that suggested that there's a higher risk of miscarriage in subclinical hypothyroidism. So again, highlighting that association in observational studies hasn't been confirmed to be causative in randomized controlled trials. So therefore, the American Thyroid Association pregnancy guidelines suggest that levothyroxine therapy should only be given for TPO antibody positive women when the TSH is greater than the pregnancy specific reference range. If you don't have that, then level of 4 should be used. So if you've got a pregnant woman whose TSH is greater than 4 and TPO antibody is positive, they should be treated. If the TSH is between 4 and 10 and the TPO is negative, then they shouldn't really be treated, which is very different to what a lot of people practice. And I've come across a lot of people, including obstetricians, using a cutoff of 2.5. And I'm sure it's based on observational studies in the past, but the evidence for treatment based on randomized controlled trials isn't really there. So to conclude, hypothyroidism is common in women, and especially in older people. And recent evidence suggests that most older people with mild TSH elevations do not require treatment. Subclinical hypothyroidism in pregnancy should be treated if the TPO levels are positive or if TSH levels are greater than 10. A personalized approach is required for managing individuals, and several factors including age, symptoms, level of TSH, the length of time it's been monitored should also be taken into account, along with comorbidities. And when treatment is initiated, the aim should be to keep TSH levels within the reference range. So just to highlight which persons with sustained SCH or subclinical hypothyroidism should be treated, in my view, I think every adult above with a TSH greater than 10 on more than 2 occasions, pregnant women with TSH greater than 10, and in TSH less than 10 if they're aged less than 70 with high cardiovascular risk or symptoms of hypothyroidism, and pregnant women with positive TPO antibody levels. So again, just to highlight finally that we shouldn't really be controlled by numbers. We use numbers as part of a diagnostic range of tools to assist us in managing our patients, but the values of the results are not the sole basis on how we manage our patients. So thank you very much, and thank you once again for your kind invitation.
Thank you, Dr. Salman. I think that is a very crisp presentation. To say in medical language, the topic was subclinical, but the presentation was overt. So thanks for your presentation. And we really appreciate your participation from UK. Please stay back for the panel discussion, which is going to be in next few minutes. And now we have got a very proud moment for all of us at the RSSDA family. For the first time, we are releasing the RSSDA guidelines 2021 recommendations on thyroid disorders in diabetic patients, both in type 1 and type 2. And we have a great topics ahead, and we'll move on to the context setting by our president of RSSDA, Dr. Bansi Sabu, who is a chief diabetologist and chairman of Diabetes Care and Hormone Clinic at Ahmedabad. He is the current president of RSSDA and is an executive committee member of International Society for Pediatric and Adolescent Diabetes. And he's been in various epidemiological studies, part of it in obesity in children, like the ICMR India study. And he's also a founder and of an NGO named Diabetes Care India. He's doing a great job. I'm sure all of you have witnessed the RSSDA success during the pandemic era of 2020. Over to you, sir, for a few words about the context setting, about the guidelines of RSSDA and thyroid disorders.
Hello to everyone attending this session. I take this opportunity to also wish all my friends and colleagues a very happy and prosperous New Year. Today is a very important occasion for us as we are launching RSSDA 2021 guidelines for thyroid disorders and diabetes. We all know that India is diabetes capital of the world, but also we have asked our question that whether India is also a thyroid capital of the world. The prevalence of thyroid disorder is higher than diabetes, which is 11% overt hypothyroidism, and clinically subclinical hypothyroidism is around 8%. Thyroid is a small gland, but it has got a major impact influencing all other tissue and organs function. Diabetes mellitus and thyroid are the two most common endocrine disorders, which are also found coexist in our clinical practice. The prevalence of hypothyroidism in type 2 diabetic patient is approximately 26.8%, and that of subclinical hypothyroidism is 22.22%. In the presence of other comorbidities like hypertension, risk of hypothyroidism in type 2 diabetic patient is elevated to almost 33.5%, and the coexistence of type 2 diabetes and thyroid in several complications which become difficult to manage in clinical practice, especially in the absence of clear screening and treatment recommendation. Many times, the cause of uncontrolled diabetes could be hypothyroidism. Therefore, if hypothyroidism is not diagnosed early, it may further impact the treatment outcome in diabetic patients. Due to higher prevalence of hypothyroidism in Indian population, there is a need for regular screening and evaluation so to reduce the risk of misdiagnosis because of lack of clinical sign and symptoms. In 2021, RSSDA guidelines, which will provide recommendation for co-management, screening, treatment of type 2 diabetes and diabetes in coexistence so that early measures can be instituted for reducing the risk of complication and respiratory complication and cardiac comorbidity. Many of you must be aware that January month across the globe is celebrated as Global Thyroid Awareness Month, and it is recognized by American Thyroid Association. And we take this pleasure to launch 2021 RSSDA guideline on thyroid disorders and diabetes on the occasion of Global Thyroid Awareness Month. Thank you. Thank you very much.
In diabetes. Along with Dr. Bansi Sabu, our president, I think, again, he's done a remarkable job in the last year during the pandemic, and that's something more important. And we say, when you have a good lieutenant, the war is half won. And he is our lieutenant leading all of us in this fight or war against the diabetes management in our country. And for the first time, we're releasing the thyroid guidelines for helping our physicians to have a better care for our patients. Over to you, sir.
Thank you very much, Dr. Srinivas Murthy. And I would like to congratulate API API DIAS as well as Abbott for helping us with this guideline that we're going to release, the RSSDI guidelines to this platform. Dr. Bansi Sabu just elaborated the association of thyroid and diabetes, and we're going to have three stalwarts who have helped in the making of the guideline: Dr. Krishna Sheshadri, Dr. Rakesh Sahai, and Dr. Sujay Ghosh, along with a host of other experts. The idea of bringing out these guidelines have been that we do recognize medicine is always a ever dynamic, changing field, and new evidences keep coming up. And it's difficult for everybody to keep pace with all the changes. The RSSD has taken upon itself that how associations with diabetes with different disorders, we can highlight it, bring out guidelines, and sensitize all the doctors across, make them aware about what has changed and how it impacts their practice. The guidelines that we made for 2021 have been updated right up to the last journal, which has come out in 2021. And I would like to really specifically thank Dr. Krishna Sheshadri, who's put in a lot of efforts, created the architecture of the entire guideline, and has been very well supported by Dr. Rakesh as well as Dr. Sujay, with the entire panel of experts, which you'll see in the guideline that have been highlighted, and the executive committee of the RSSDI. Together, all the heads have gone in to make this guideline, and I'm sure you'll find it very useful to use it in your clinical practice. Excerpts of this guideline will be presented today by the three speakers. Also, I would like to end up by thanking Abbott for supporting this entire guideline. Without their assistance, this guideline wouldn't have seen the light of the day. We've had earlier presentation from Mr. Anil Joseph, who really talked about the marathon efforts that Abbott does in bringing out all the different diagnostics, therapeutics, and supports for the educational program for various fields. And Abbott is very closely associated with diabetes care, and we saw that in his presentation. They have been very supportive for all the educational initiatives that we do along with the RSSDI, and we continue to look forward to support from them even in future. With these few words, I would like to really first invite Dr. Rakesh Sahai, Dr. Krishna Sheshadri, Dr. Sujay Ghosh, Dr. Arul Raj, and Mr. Anil Joseph to the platform for the inauguration of the RSSDI 2021 guidelines, which we will unveil today, and then it will be available for everybody to read and to definitely implement in the clinical practice. So can we have the inauguration ceremony, please? Thank you very much, and a big round of applause for the guideline and all the efforts that have gone into making the guideline from all the people who've contributed to it. So we'll move on with the scientific program now. And we're going to have three very interesting lectures, starting with, of course, first one from Dr. Rakesh Sahai. He's going to speak to us on update on current evidence and guidelines on thyroid disorders and type 2 diabetes. A little word about Dr. Rakesh Sahai. He's a professor and head of endocrinology at the Osmania Medical College and General Hospital, and he's a senior consultant endocrinologist at the Aster Prime Hospital in Hyderabad. He's the vice president of the South Asian Federation of Endocrine Societies for the period 2019 to 2023. He's a member of the National Advisory Board of Thyroid Research and Clinical Practice, Journal of the Indian Thyroid Society. He's a recipient of the Justice Uma Maheshwaram Oration of Hyderabad chapter of Association of Physicians of India, which was given to him in December 2019. And he's received the Best Teacher Award in Medicine by the Government of Telangana in 2018. With these few words, I would like to hand over the platform to Dr. Rakesh Sahai for his presentation. Over to you, Dr. Rakesh Sahai.
Thank you, Dr. Sanjay Agarwal, for the kind words of introduction, and it's really an honor to be on this platform to discuss about the issue of thyroid and diabetes and the guidelines which have come out from the RSSDI. Is my screen visible?
Yes, it is. You'll have to just make it full. It's visible now.
Yeah. Thank you once again for the invitation to be here, and it's indeed an honor to be here on this platform and to discuss about the current evidences and all the guidelines on thyroid disorders and type 2 diabetes with diabetes. So if you look at the problem of thyroid disorders and diabetes, they are probably the two most frequently seen endocrine disorders with variable prevalence in different populations, but by and large they are the most prevalent ones across the globe. And the other important aspect is that the thyroid hormone is a regulator of the metabolic and energy expenditure processes, which is directly involved in the regulation of insulin secretion as well as the maintenance of glucose homeostasis. And the coexistence of thyroid disorders and diabetes mellitus results in several complications which become difficult to manage in clinical practice, especially in the absence of clear screening and treatment recommendations. So there is a clear need for a better understanding about these two problems, how they interact with each other, and what should be our approach towards screening for each of these problems and how to manage each of these problems when they coexist. So if you look at the issue of thyroid disorders, whether we're looking at hyperfunction or hypofunction of the thyroid, what we see is that the ultimate consequence is insulin resistance. So there is a clear-cut effect on diabetes when you have thyroid dysfunction. So if you look at hypothyroidism, basically what we are seeing is that there is a decrease in activity of the GLUT4, and thereby there is decrease in clear insulin resistance, and also there is because of which there is a problem in glucose utilization, and the thyroid hormones clearly influence the glucose utilization, and in the absence of in presence of lower levels of thyroid hormones, you have problems in glucose utilization. On the other hand, when you look at thyrotoxicosis, it affects at several levels. It affects the insulin sensitivity again. It leads to insulin resistance at several different levels. It has effects on the hypothalamic paraventricular system. It leads to increased sympathetic activity. That again leads to increase in insulin resistance, and it also at the level of the liver, it leads to problems and also increases the beta cell apoptosis. Through all these mechanisms, there is a clear interaction between hyperthyroidism and diabetes. Again, there is in simple terms, we could say that both of them lead to increase in insulin resistance and influence the glucose metabolism. Now, there are many interesting observations that have come out recently. You have the data that shows that decreased plasma nesfatin levels are clearly related to thyroid dysfunction in patients with diabetes. And this is something which has been shown in in patients with type 2 diabetes, where you could see here the clear reduction in the levels of plasma nesfatin levels, and nesfatin has been shown to have a crucial role in energy and glucose metabolism, and it may act as a regulatory factor of thyroid function by adjusting the AMP kinase activity and the thyroid receptor, the thyroid hormone secretion in patients with type 2 diabetes. So at different levels, you have this association. And if you look at, once again, look at how hypothyroidism is affecting the glucose metabolism, glucose homeostasis. I was just speaking about the decrease in blood-4 activity, which is important for insulin uptake into the peripheral cells and insulin action into the peripheral cells. In addition, hypothyroidism leads to decreased gluconeogenesis, glucose glycogenolysis, and reduces the hepatic glucose production. And all in all, what it can lead to is that there could be frequent episodes of hypoglycemia in individuals who have unrecognized hypothyroidism. Hypothyroidism also leads to increase in the TNF alpha and IL-6, which are again, we know that these are important mediators of inflammation, and they are factors which increase insulin resistance also. Circulating ghrelin levels are also influenced by the thyroid hormone levels, and this again has important effects on insulin sensitivity, islet cell proliferation, and survival. And as we have seen, thyroid hormones have a positive association with insulin resistance, not only in patients who are diagnosed to have diabetes, but in subjects with normal glucose metabolism also. It has a significant effect on the insulin sensitivity. Now let us look at some of the current evidences on looking at the correlation of these two conditions. So if we look at some of the recent Indian data, looking at the prevalence of hypothyroidism amongst patients with diabetes alone, or those with diabetes and hypertension, we see that the prevalence recorded in patients with diabetes was 24.8% in this study from Dr. Talwarkar from Bombay, and in their group they also looked at people with diabetes and hypertension, and they found a even higher prevalence of 28.9% of thyroid dysfunction amongst these groups. Another interesting study from the group from Trivandrum, Professor Jabbar's group from Trivandrum, Dr. Abhilash Nair was the first author, and they found that this was a retrospective study which they looked at about 1,152 patients with type 2 diabetes, and looked for presence of hypothyroidism, and they found a prevalence of overt hypothyroidism of 9.83% and subclinical hypothyroidism of 5.9%. So, and when they looked at the associations of, the factors, the risk associations between these two conditions, and they identified that hypertension, dyslipidemia, and anemia are some of the common associations between these two disorders. Then another interesting study, which was done in a population which is having a high prevalence of diabetes, identified thyroid dysfunction to be very common amongst patients with diabetes, and the factors that they found important towards being risk factors for hypothyroidism in patients with diabetes was the presence of family history of thyroid disease, female gender, duration of diabetes of more than 10 years, or the presence of a goiter. So in all these settings, you would expect that there would be much higher prevalence of hypothyroidism as compared to those diabetics who do not have these factors. And the other important point that was highlighted was that patients with type 1 diabetes, it's very clearly evident that type 1 diabetes, being an autoimmune disorder, has a very clear association with other autoimmune disorders, and autoimmune thyroid disease being one of them. So what we see is that patients with type 1 diabetes have a very clearly high incidence of autoimmune thyroid diseases, and this is something which we should keep in mind and should screen for them. And there was screening for autoimmune thyroid disease in type 1 diabetes, particularly in women with type 1 diabetes, is very important, and it is necessary in all patients with type 1 diabetes, as I would show you all the guidelines from across the world showing that there is a need for looking for this association. Now, looking at the relationship between the hypothyroidism, whether it is overt or subclinical, on the various manifestations of diabetes. So if you look at subclinical, overt hypothyroidism or even subclinical hypothyroidism, they lead to increase inflammatory activity, and this in turn has a significant influence on the insulin resistance. Altered deiodinase activity is also probably one of the factors which are which are interfacing between the presence of thyroid dysfunction and insulin resistance. So this systematic review or meta-analysis of several studies of patients with type 1 diabetes has shown that there is a markedly increased risk of thyroid dysfunction in people with type 1 diabetes and thyroid autoimmunity, and the optimal method of frequency. However, this is not very clearly understood as to what should be the frequency of screening, but I would say that most of the guidelines are now reaching towards a more of a consensus about screening for thyroid disease in type 1 diabetes. It's more of a confusion when you're looking at type 2 diabetes. Now, looking at the association between hypothyroidism and the various complications of type 2 diabetes, there are several studies which have shown that individuals with overt hypothyroidism have a significant has a significant influence on the development of microvascular disease and even the microvascular disease. And it's interesting to see that even subclinical hypothyroidism has an effect on the progression of retinopathy and neuropathy and nephropathy. Treating hypothyroidism has been shown in some studies to improve the renal function in patients with diabetes. And diabetic patients with subclinical hypothyroidism have been shown to have more severe retinopathy than euthyroid patients with diabetes. And there is a higher frequency of hypoglycemic events in patients with thyroid dysfunction as compared to those without thyroid dysfunction. Coming to the issue of CVD, we had an elegant talk just now about the thyroid, about subclinical hypothyroidism, how it influences the cardiovascular disease, and so I don't think I need to say much about that, but it has been clearly shown that hypothyroidism may magnify the CVD events through altering the lipid metabolism and through several other, and also by influencing the endothelial function. And some of these aspects are reversible with treatment of of hypothyroidism, and and it has also been seen that in euthyroid persons, low normal thyroid hormone levels were associated with hyperlipidemia and insulin resistance. This is an interesting study which looked at analyzed about the data from 803 patients with type 2 diabetes who did not have any CVD at baseline. And when you look at the TSH levels within the reference range, also they had a linear and positive association with the CHD events. However, this association was not seen for new onset of AF or all-cause mortality. Now, coming to the influence of subclinical hypothyroidism, as I mentioned that the prevalence of subclinical hypothyroidism in different studies has been to the tune of about 5 to 8.6%, and it is associated with the greater prevalence of diabetic nephropathy, as was shown in the previous slide, and the risk of cardiovascular events was also significant increase in patients with diabetes with subclinical hypothyroidism. Though normal FT4 levels are significantly associated with increasing insulin resistance. The other important aspect that we have to understand is, apart from the influence of the thyroid dysfunction on the diabetes itself. Now, does diabetes influence the thyroid dysfunction, or rather, if you look at people with subclinical hypothyroidism, if they are diabetic, do they have a higher risk of progression to overt hypothyroidism? Is a question which has not been very clearly answered. Some studies, like the study by Gray et al., they have shown a progression rate of 5% per annum from subclinical to overt hypothyroidism amongst patients with diabetes, as compared to other studies which have not shown this difference. They have, in fact, not shown this difference, and so therefore this area is something which is not yet clearly understood, whether the diabetes has an impact on the progression of subclinical to overt hypothyroidism. Now, finally, I would just give you a snapshot of what different guidelines across the world are saying about this association and about screening of patients with type 1 diabetes and type 2 diabetes for thyroid dysfunction. As you can see, when we start off with type 1 diabetes, there more or less there's a sort of uniformity of what different associations are saying. You can go through this, but essentially what they're saying is that you need to look for the thyroid function in the form of assessing the TSH levels and doing the thyroid TPO antibodies at diagnosis and at every year thereafter. While the TPO antibodies may not be mentioned by each of these associations, but the important parameter that has to be studied is the TSH levels at diagnosis and at every year thereafter. That is the essential message from all the guidelines across different parts of the world. Whether you look at the British Thyroid Association, the American Diabetes Association, or any of these associations. The Indian Thyroid Society has also recommended screening for both for thyroid dysfunction in patients with type 1 diabetes. When you look at some of the other associations like the International Society for Pediatric and Adolescent Diabetes ISPAD has recommended screening for thyroid disorders at the starting from the age of 10 years amongst the children with with diabetes. They have suggested 10 years as a starting point for starting evaluation for thyroid dysfunction, or at the beginning of puberty, and at every 2 years thereafter. And the ACE, the American Association of the Association of Clinical Endocrinologists of Italian Societies, of the Italian Society, has recommended at the time of the screening for TSH, TPO antibodies, and thyroglobulin antibodies at the time of diagnosis of type 1 diabetes in children, and annual evaluation of TSH in TPO positive children, TPO antibody positive children, and biannual evaluation, that is once in 2 years evaluation for those who are negative for the TPO antibodies. So again, the purpose of doing the TPO antibodies probably helps in stratifying as to those who require more frequent subsequent evaluation as compared to those who require less frequent evaluation. Now, coming to type 2 diabetes, there's a lot of heterogeneity between what the different associations have been speaking. Some of the associations like the ADS has spoken about palpation of the thyroid in all patients with diabetes, and screening for TSH only in those who are more than 50 years of age, or in patients with diabetes who have dyslipidemia. While the American Thyroid Association, the American Association of Clinical Endocrinologists has spoken about thyroid palpation and TSH at diagnosis and at regular intervals in patients with goiter and autoimmune thyroid disease. Screening of thyroid disease in older patients, and especially women with diabetes. The other societies like the American Thyroid Association and the Endocrine Society have suggested thyroid screening every 5 years for individuals above the age of 35, and TSH screening should be performed at the time of diagnosis of DM and every 5 years thereafter. So, as we can see, there is a difference. I mean, different societies have had little differences in their recommendations. Thyroid palpation has been highlighted, and doing it amongst older people and those with other comorbidities like dyslipidemia has been the essence from most of these guidelines. Now, regarding pregnant women with type 1 or type 2 diabetes, there is a clear-cut recommendation from all of them that we should screen all women who are planning for pregnancy, particularly type 1 diabetes who are planning for pregnancy, for TSH and anti-TPO antibodies, and TSH and TPO antibodies should be repeated during the early pregnancy, and those with positive TPO antibodies and normal TSH during pregnancy, TSH levels must be evaluated at 3, 6, and 12 months postpartum. That's what the American Association of Clinical Endocrinologists and also the Italian Association of Clinical Diabetologists has been recommended. And if you look at what the other associations like the American Thyroid Association says, they recommend women with type 1 diabetes to have a reflex anti-DPO evaluation. It needs to be conducted if the TSH levels are between the range of 2.5 to 10, and they do not recommend that all of them should have the same have the anti-DPO antibody, but only those where their TSH is between 2.5 to 10 they have recommended that. Then there are other recommendations regarding treatment of patients with diabetes with coexisting thyroid disorders. There has been a mention of using metformin, particularly because metformin treatment reduces the incidence of thyroid cancer, and it could be a useful agent to be used in patients with diabetes along with coexisting thyroid disorder. And treatment of both overt and subclinical hyperthyroidism in patients with diabetes has also been mentioned by the European and American Thyroid Associations. So this is what different guidelines have spoken about screening for screening amongst patients with type 1 diabetes, screening among patients with type 2 diabetes, and also looking at pregnancy. So I would end with the following take-home messages: that thyroid dysfunction is more common in patients with diabetes than in the general population, and they are frequently asymptomatic. Undetected thyroid disorders can have an influence on the metabolic control and amplify the risk of CV and microvascular events. And screening for these events could help in influencing the development of the cardiovascular complications. And subclinical hypothyroidism also can influence the risk of development of microvascular complications. And there could be an influence of regulating the treating with thyroxine could have an influence on the fasting hyperinsulinemia and significantly improve the insulin sensitivity in patients with overt hypothyroidism and insulin resistance. So with that, I would conclude, and we would take up the questions in the panel discussion. Thank you.
Thank you very much, Dr. Sahai. Wonderful presentation, very crisp. And I would like you to stay back for the panel discussion to take questions. Our next speaker is Dr. Krishna Sheshadri, and he would be speaking to us on RSSDI recommendation for screening and treatment for thyroid disorders and diabetes. A word about Dr. Krishna Sheshadri. He's a visiting professor at the Sri Balaji Vidyapeeth College and is a senior consultant endocrinologist and diabetes at Apollo Hospitals. He's a senior clinical research at the director of a education company and PAMS, a not-for-profit organization. He's the editor-in-chief of Thyroid Research and Practice and associate editor for Journal of Diabetes in Developed Countries on endocrinology and metabolism.
Can I start, Sanjay? Can you hear me?
Oration and medical education. Yeah, we can hear you, Krishna. Over to you for your lecture.
Okay, thank you. Thanks, Rakesh, for setting the tone for these guidelines. It was a very, very long talk. And I would like to thank the RSSDI and the API for giving us this opportunity. Thank the lead authors in this paper and the extended panel of experts for their valuable contribution in creating these guidelines. Can you, next slide, please? Please remember my conflict of interest. I have speaking on the area in the past. So it's important to understand two parts. One is that you have two diseases that are very prevalent. And as Dr. Sabu said, that hypothyroidism is even more common than diabetes in the Indian population. So when two common diseases overlap, the question is whether they influence each other's occurrences. And should you screen for one when the other is present? And that is a dilemma that the world has tried to address over a period of time, very unsuccessfully, because many studies have come out and we still don't have a level 1 evidence to make a clear recommendation for many things. So this particular background is something that we need to be aware of when we review these guidelines. Remember that type 1, they are both common. In the Indian population, around 9.8%, with type 2 diabetes have clinical hypothyroidism, and about 6% have subclinical hypothyroidism. And in India, the prevalence of hypothyroidism in type 2 diabetes patients in another study is about 26.8%, and the prevalence of subclinical hypothyroidism is about 22%. And this was the study by Ali et al. Next slide. Right, so I will focus on screening and treatment for thyroid disorders and type 2 diabetes mellitus. Dr. Sujoy Ghosh, one of the lead authors in this particular guideline, will bring up the rest of it. Next slide. So one interesting thing, and this is Dr. Sujoy Ghosh's article, is a cross-sectional study of 234 patients with thyroid dysfunction and diabetes, and one of the things that they observed, and again this was also seen in the Trivandrum group's paper, where when you have uncontrolled diabetes, when you have other comorbidities, there was a higher incidence of hypothyroidism. Also, in this particular study, they recommended DIAS screening in patients with uncontrolled glucose levels. Next slide. So in a cross-section study, and this is looking at a cross-section study of 364 patients with type 2 diabetes, and they suggested that high-risk condition must be screened for thyroid dysfunction. But one thing that is important is to remember at this point of time, we still do not have a data to suggest that all patients with type 2 diabetes need to be screened for hypothyroidism or thyroid dysfunction, and this is mostly case finding. We will look at the final recommendation, but at this point of time, the data does not support routine screening with TSH in all patients with type 2 diabetes. In a retrospective analysis of around 339 patients with type 2 diabetes, they suggested targeted screening for patients with poor glycemic control, and that seems to be something that is fairly well looked at the early picture. This is the cross-section study of 8,258 participants, and it identified elderly women with uncontrolled type 2 diabetes as a high-risk patient and recommended annual screening for them. Next slide. Can I have the next slide, please? Yes. This is something very interesting, and this is the question is what happens when you use therapies. The first important thing to remember is that metformin works by increasing AMPK, and two things happen. One is when you treat with thyroxine, there is a reduction in A1C in patients with type 2 diabetes, coexisting subclinical. Interestingly, metformin seems to reduce TSH levels. Next slide. The question is this clinically significant? Next slide. Right. In this particular study that is published, after 1 year of metformin therapy, they noticed a significant decrease in diabetic patients with hypothyroidism who were either treated or untreated with thyroxine. A 30% shrinkage in the initial size of the nodule that was present was also seen when metformin alone was addressed, and up to 55% when it was added to thyroxine. So this is one particular study that shows the effect of metformin on TSH as well as thyroid size and nodule. Next slide. Right. Remember that sulfonylureas will reduce iodine uptake. We are not sure whether this may affect the clinical condition of the patient. We'd always be aware of this. One important thing that we know, and this we know from the early 2000s, is thiazolidinediones can actually worsen Graves' orbitopathy. There are patients who have a history of thyrotoxicosis to whom glitazones have been added, and they present with worsening of orbitopathy. So it's important to understand that this must be very careful be used in patients with Graves' orbitopathy. In patients with diabetes who do not have orbitopathy, with hypothyroidism, there are no issues, but with thyrotoxicosis, we must be careful. Next slide. So let's come to the recommendations, and of course, the full text is available for all of you. Next slide. This is from British Thyroid Association in type 2 diabetes. They recommend thyroid function tests at baseline. they do not recommend routine annual screening. The ADA recommends palpation in all diabetic patients, TSH in adults greater than 50, or patients with dyslipidemia. The AACE talks about thyroid palpation and TSH diagnosis in regular intervals with goiter and PID. They recommend screening for thyroid dysfunction in older patients, especially women. ISPAD does not have specific recommendations. Their area is different. The ATA talks about more frequent TSH evaluation in patients with type 2 diabetes. Next slide. So what is the RSSD I recommend in type 2 diabetes? Next slide. One, routine screening for type 2 diabetes is not necessary for patients with type 2 diabetes, but it may be favorable depending. And for patients above the age of 35 years, without any additional risk, TSH screening is recommended every 5 years. Again, this is based on many other societies, and this will probably change as more data accumulates. In patients who have a TSH of 2 and or positive anti-TPO, we may consider annual screening again, a grade B recommendation. Next slide. Now, this is something that you have more data for. Somebody with uncontrolled diabetes, we have data, also international data, and the presence of comorbid conditions like hypertension, dyslipidemia, poor glycemic control, complications, and those who frequently visit the hospital for poorly managed type 2 diabetes. Annual TSH screening seems to be warranted. Above the age of 65 years, especially women, annual TSH screening is recommended, especially in the presence of macrovascular complications and comorbidities. In those above the age of 50 years, if there is a history of dyslipidemia and other comorbidities, annual screening. So this seems to be a balanced recommendation that has come from the data that has been accumulated over a period of time. Next slide. Now, in patients with type 2 diabetes, pre-diabetes, gestational diabetes, and risk factors such as obesity, must screen in the first trimester, regardless of the level of diabetes control. And women with positive TPO antibody screened at 3, 6, 12 months postpartum. I think this doesn't require any justification simply because this is pretty much standard of care throughout the world. Next slide. Next slide. Now, I think we need to be very clear that metformin can be safely prescribed in patients with type 2 diabetes, we need to monitor the glucoses as well as the TSH levels at prescribed standard doses. You really don't have to go for a reduction in the thyroxine dose, but if you see TSH reductions that are present, remember that all patients do not have TSH level reductions. If these are significant, then dosage reduction of levothyroxine may be required. Next slide. So this is a summary of the screening, diagnosis, and treatment recommendations for coexisting thyroid disorders, a baseline TSH, and maybe an antibody. If they have thyroid dysfunction, that is overt, appropriate treatment and monitoring. In subclinical thyrotoxicosis, if the TSH is less than 0.1, treatment. If it is between 0.1 to 0.4, you can consider treatment if they are elderly, their atrial fibrillation, CV risk factors, osteoporosis. In subclinical hypothyroidism, use your clinical judgment and the presence of antibodies. Cardiovascular risk factors that Dr. Rakesh Sahai mentioned, whether goiter is present or what I do if the TSH rises over a period of time. Start. If the TSH is greater than 10, the treatment and monitoring is required. In euthyroid patients, in type 2 diabetes, if they are anti-TPO positive, then appropriate monitoring, probably based, if they're over 35 once in 5 years. In type 1 diabetes, there is clearly data to suggest that annual screening is important. Next one. So I will stop here, and I think Dr. Sujoy will bring in the rest. Back to you, Sanjay.
Thank you very much, Krishna. I'd like to thank you very much for this crisp presentation. And our last presentation for the evening is going to be by Dr. Sujay Ghosh, and he's going to talk to us about the RSS's recommendation for screening and treatment for thyroid disorders in type 1 diabetes and thyroid cancer. A word about Sujoy. He's the associate professor in the Department of Endocrinology at IPGM ENR and Calcutta, and is attached to the Amory Dhakuria. He's the editor-in-chief of Oxford Handbook Series and the executive editor of Thyroid Research and Practice and the Indian Journal of Endocrinology and Metabolism. He's the Secretary General of the Endocrine Society of India, and he's been awarded with the Dove Innovation Award in 2018. Over to you, Sujay, for your presentation.
Good evening, and thank you very much. Hopefully, I'm audible and my slides are visible. Thank you, Dr. Sanjay, for that kind introduction, and a big thank you to RSSDI as well as API for having given me this wonderful opportunity to present before you the RSSDI recommendations for thyroid disorders in type 1 diabetes and a little bit about thyroid cancer. My job has been made much easier by my previous speakers, respectively Dr. Professor Rakesh Sahai and Dr. Professor Krishna Sheshadri. And a lot of the stuff that's there on the slides is repetitive, which I will skip because we are already running short of time. So we've already known that thyroid disorders might coexist with type 1 diabetes and other forms of diabetes, and that there might be a two-way relationship wherein the thyroid disorder might influence the outcome of diabetes, and presence of poorly controlled diabetes might actually influence thyroid disorder. In case of type 1 diabetes, both of them might share same etiology, because type 1 diabetes, as you know, in most forms, that is at least type 1A, is an autoimmune disorder, and most of the thyroid disorder that happens in type 1 diabetes is autoimmune thyroid disease. And Dr. Rakesh Sahai has already told us about how glucose metabolism can be influenced by thyroid dysfunction and how micro and macrovascular complications might worsen. So let's talk about screening for people with type 1 diabetes. Now, most of literature would suggest that there is a need for screening for thyroid disorders in patients with type 1 diabetes. And like in the last of his slides, Dr. Krishna already suggested that there's probably a need for annual screening of TSH in individuals with type 1 diabetes. Now, if we look at various studies, including clinical practice guidelines, particularly this particular study suggests that if you screen people annually, you're quite likely to pick up patients who develop thyroid dysfunction, even if they are asymptomatic and have type 1 diabetes. Now, coming to my part of the world, India, and this is a study from Eastern India by Deb Mallo, a junior colleague of mine, who kind of...
Sujay, the slides are not moving, I think.
They are not moving at all?
You are on the third slide still.
Can you see my slides now?
Yeah, we can see your slides, but
yeah, now they are moving. Yeah, now they are moving.
Okay, right. Sorry for that glitch. If you look at this particular study from Eastern India of the frequency of autoantibody positivity in type 1 diabetes, if you look at anti-TPO antibody, almost about 50% of subjects had autoantibody anti-TPO positivity, and about a quarter of our patients had anti-thyroglobulin antibody. Apart from the other autoantibodies, which I'm not going to talk about here, but what's interesting is to see that autoantibodies specific for thyroid organs such as anti-TPO and anti-TG were discordant. So it's not necessarily that everybody who was anti-TPO positive was anti-TG positive. But what's important is both antibodies were present in about 20% of the subjects. Both were absent in about 45%. And any one of those antibodies was present in at least 50% of the population. And anti-TPO positivity correlated with duration of type 1 diabetes. And about 9% of the total population were hypothyroid and 15% had subclinical hypothyroidism. But what's interesting is all patients who had clinical or subclinical hypothyroidism were anti-TPO positive. So if you have to choose only one antibody, probably the anti-TPO antibody is the one to go for, because at least as far as clinical disease or manifestation of disease was present, it's the anti-TPO antibody rather than anti-TG antibody. 23% in addition were anti-TPO positive, but they were euthyroid. Looking at other antibodies, because we've looked at a whole lot of other antibodies, could some of the antibodies which we use for diagnosis of type 1 diabetes be used to tell us that this individual more likely to have thyroid dysfunction?
Hello.
Yes. And of the antibodies, anti-ZNT8 was the antibody which showed that there was likelihood of thyroid dysfunction. Even in type 1 diabetes, what is interesting to note that subclinical hypothyroidism increases insulin resistance and increases the chances of having problems as far as glycemic control is concerned. To coming to the recommendations of type 1 diabetes and thyroid disorder screening by the ISSDI, I think a lot of that has been already stated by my previous speakers. The British Thyroid Association talks about TSH and anti-TPO at diagnosis and every year. Most of the other groups would suggest similar stuff. The ATA sometimes suggests that there might be a case for even more frequent sampling. The RSSDI guideline talks about screening for anti-TPO antibodies as well as TSH at the time of diagnosis of type 1 diabetes, whether they're euthyroid or not. If the patients are positive for anti-TPO and annual screening, you will go on. If they are negative for anti-TPO, maybe you can increase the time span between screening, where it can probably be done every second year. With regards to pregnant women and children with type 1 diabetes, everyone should be screened, preferably even before conceiving, if not at least during the first trimester. TSH screening is also recommended with anti-TPO antibody at the time of planning. Women with anti-TPO positivity should be screened for thyroid dysfunction, even if they are euthyroid at the beginning of pregnancy, every trimester, and again then postpartum, 3 months, 6 months, and 12 months, because we know these are individuals who are more likely to develop hypothyroidism. Anti-TPO evaluation as well as TSH screening in children and adolescents at the time of diagnosis is something that I've already talked about. In terms of treatment, standard treatment, there's nothing different in patients with type 1 diabetes as compared to other forms of diabetes and thyroid disorder. Just a few slides about thyroid cancer. There have been several studies to try and look at whether there is increased association with thyroid cancer in patients with diabetes. The predominant reason is because, if you think someone's got insulin resistance, what are the chances of having increased risk? There's very little to actually make recommendations or statement that there is any increased risk of thyroid cancer in patients with diabetes. So there is no strong link between diabetes and thyroid cancer. And if you talk about the recommendation, it would be standard palpation of the thyroid gland for every patient with diabetes. If you do have a significant nodule, go for an ultrasound and FNA were recommended. And one of the things that Dr. Krishna already talked about. Metformin might have some role in terms of reduction in the size of the nodule, and GLP-1 analogs at one point of time was implicated for medullary thyroid carcinoma. I think that bit is finally sorted. And this bit of the screening has already been discussed, so I'll not bore you with that. Just to remind you, type 1 diabetes, screening at diagnosis and annually, anti-TPO as well as TSH. If the individual is euthyroid and anti-TPO is negative, then maybe that screening duration can be increased. Thank you very much.
Thank you very much. Yeah. Thank you very much, Sujay. And I'm going to invite all the panelists on the dais. Can we have all of Dr. Rakesh, Dr. Krishna Sheshadri, as well as Dr. Sujay Ghosh, and we're going to sort of have a lot of question and answers that are going to be there with us. And also, can I have Dr. Salman Razvi, if he's around, so that we can have questions for all. Let me just pull out the questions and then we can start off. Give me a minute only so that I can pull out the questions. Okay. Is Dr. Salman there? Yes, okay. Let me start with you, Dr. Salman, that if the patient is having a TSH of around 5 and is having symptoms, I mean, you did come up with a very elaborate discussion about how we should approach this patient, but still there is some sort of, doubts as to, people are not very clear about how we should approach in terms of treatment. So if you have somebody who's symptomatic as well as asymptomatic, I would like to address both parts of it, with an HbA1c of 5 in the middle-aged population, perhaps, what would the treatment approach be?
If you have somebody with a TSH level of 5 and that's consistent over a period of time, and they have symptoms of hypothyroidism, the difficulty we have is what are the symptoms of hypothyroidism? And I think that there is nothing specific. They're all vague and non-specific symptoms. So knowing for certain whether they are related to the thyroid dysfunction or not is difficult. And the only way to find out would be with a trial of treatment. So if you have a middle-aged to younger person, and my criteria for defining middle age increases every year. So currently, my definition would be up to the age of 65 or 70. If you have somebody with a mildly elevated TSH that has been stable for a period of time and have symptoms that could be due to hypothyroidism, then I think a trial of appropriate dose treatment with levothyroxine for at least 3 months would be reasonable. If after 3 months there is no improvement and the TSH level is well within the reference range, then I think we can safely assume that the symptoms were unrelated to the thyroid dysfunction. And I would also go to the extent of saying we can stop the levothyroxine because up to half the people will actually normalize the TSH levels going forward. So I think that'd be my view on this question.
Do you do the antibodies for all of them if you've before initiating treatment, or it's not required?
I think it's helpful to know what might be causing it. TPO antibodies are useful as a guide to stratify people based on the risk of progression. It doesn't really impact on either the cardiovascular risk or on their symptoms. So it might influence me in whether I decide to stop treatment after 3 months or not, but not necessarily at the initial point.
Okay. Rakesh, can I ask you a question? This is from a doctor on the chat, and he says that I have a patient whose TSH levels are not getting controlled despite being on almost 150 microgram of thyroid replacement. What should he do about this? So how does he dose escalate, or what should be the next step forward? You're not audible. I think you need to unmute. Rakesh, you need to unmute.
Yeah. Sorry for that. Yeah. So I think one of the important things about thyroxine therapy is that, proper use of the therapy. I mean, in the sense that taking it at the appropriate time with on an empty stomach is important. And many times people falter on this, and they probably have been taking large doses and not seeing the reduction in TSH happens quite often, and looking into that is very important. Looking into the timing of use of medication, and these issues have to be looked into. Once that issue is sorted out, then we would probably need to increase the dose and adjust it as per the response that is being seen.
Do you recommend that if the patient is, because very often we see this happening in clinicians, that if they're needing very high amounts of replacement, then they split the dose, or very often they give twice a day doses. Do you recommend giving, when you're supposed to giving more than 200 micrograms, that you give it twice a day?
Twice a day doesn't have any rationale, because thyroxine has a very long half-life. It has a half-life of almost 7 days. So there's no rationale for giving it twice a day. Rather, it should be timed at a time when the absorption is expected to be the best. So particularly, there could be individuals who are taking it early in the morning, and immediately after the tablet are having their breakfast, and not having enough time for the absorption. So such individuals can probably take it late in the night when they're going to bed also. So identifying a particular time of the day when it's best suited for them is important, and splitting the dose has no benefit.
Okay, this is to Sujay. Sujay, is thyroid screening recommended for all patients having hypertension?
No. There would be no specific reason why everyone with hypertension needs to be screened. But on the other hand, if you're looking at, one of the indications, or I would say a soft indications for treatment of subclinical hypothyroidism would probably be dyslipidemia. So if you just screen someone with any chronic disease, metabolic disease, like say hypertension, and you would be doing a lipid profile, and you would be looking at cardiovascular disease, there you found someone who's got subclinical hypothyroidism, there might be some indication. Otherwise, screening everyone for hypertension, there is no specific indication. The only thing that you would say is both hypertension is very common disease, hypothyroidism is a very common disease, and then again you might find studies which will show that there are some association, but not necessarily causal relationship.
So which brings me up to the next question, and this is to Dr. Salman, that does treatment of subclinical hypothyroidism improve lipid abnormalities?
Yes, so it does that. So appropriate and adequate treatment has been shown in several randomized controlled trials to have a modest effect on LDL cholesterol, apolipoprotein B, and so on, without an adverse effect on HDL cholesterol unless it is overtreated. The average reduction in LDL cholesterol is about 0.2 millimoles per liter. I'm not entirely clear how much that would be in milligrams per deciliter, but it wouldn't be a huge amount. So it's not the kind of effect you would see with a statin, for example. So it's a very modest effect of treatment.
Okay, Krishna, this is for you. Which are the types of patients with diabetes where you think that thyroid function should be screened annually? Krishna, you're muted. We can't hear you.
Okay. First, let me reiterate, there is no data for screening TSH in everyone with type 2 diabetes. So which means we are doing case finding. Who are the ones that probably benefit? One, those who have comorbidities. Diabetes with hypertension, diabetes with renal failure, diabetes with heart dysfunction. Those who are having uncontrolled glucoses, as some of the studies suggest. And lastly, those who end up going to the hospital more frequently with diabetes. These are the people in whom screening for thyroid TSH seems to be useful and more productive and not a waste of people's money. So I would identify these people: those with high glucoses that are uncontrolled, those who have comorbidities, those who have, of course, symptoms and signs of hypothyroidism, those who have obesity and dyslipidemia. And lastly, those who end up going to the hospital more often. These are the 5 groups of patients in frequent DSH screening report.
Well said. Does anybody want to add anything? Okay. This is next question is to Dr. Salman again. This is from Dr. Anjana Adhikari. What she wants to ask you is subclinical hypothyroidism in pregnancy and its treatment has always been a subject of dilemma, especially when TSH is above, in pregnancy is above the specific range and less than 10 and TPO antibodies negative. We usually treat in fear of miscarriage, risk of preeclampsia, and low IQ of offspring. But according to today's presentation, if TSH is less than 10, there is no harm in not treating, sorry. So what do you suggest? I mean, are you going to be medically legally liable? That's more important.
So I think that has always been the concern that people, when you treat a pregnant woman, you're treating 2 people at the time, and that view was based mostly on associative studies, which looked at the mother's TSH levels and the offspring's IQ, or the association with miscarriage and so on. 2 large randomized controlled trials of several hundred pregnant women in Cardiff and in the US have shown that there is no benefit in treatment, particularly when the TPO antibody is negative. So based on that, we can conclusively show that there is no benefit in treatment if the TPO antibody is negative.
Great. Because you see, our gynecologist colleagues always are that, we should treat all patients above 2.5. And that, as you rightly said, you dispel that entire myth that, we need to keep the cutoff as 2.5. And that's where probably most of the people are concerned that are we really on right ground to refuse to treat patients in that sense? So, Krishna, would you like to add what you do in India? I mean, are you conversing with the same thought that because you practice it in India, you know how people work in India. So what is your view about the same thing?
So I think, what has happened is this is a space, and, like gestational diabetes, there is always a churning of recommendations. And in the last few years, we have realized that we are overdoing this bit. And, 2.5 to 4 is a gray area. And we actually have a conversation with the gynecologist and say that I don't think we should be treating this. But I would, if somebody has a TSH of 2.5, I would follow them carefully. This is one. The second thing is that remember that, and just adding this, a lot of times gynecologists have concerns when someone is detected to have hypothyroid pregnancy, whether they should counsel termination, right? And this is something that comes up often, right? People come to us panicking, TSH is 100, the TSH is 75. Keep telling them that, the level of TSH does not tell you the severity of the this tells you the briskness of the response. So, and there is no indication to actually counsel termination of pregnancy. The TSH is very high. So I think that's and what we practice exactly what Razvi spoke. It just needs a little more education with the gynecologist, reassuring the patient, because a lot of times by the time they've come, they've seen enough WhatsApp and Google groups to be wired for sound. And it requires a lot of sitting down.
Great. This next question is again to you, Krishna, that should the initiation, this is from Dr. Shashank Tandon, and should the initiation of the pharmacotherapy for subclinical hypothyroidism differ in diabetic patients as compared to the general population?
No. In one word, no. Just to expand on this, remember that initiation for hypothyroidism, I would be careful to get coexisting coronary artery disease, whether these are people with hypertension, long-standing hypothyroidism, to decide whether the regular dose and the age decide the regular dose or a small dose is required. Subclinical hypothyroidism, just the presence of diabetes alone is not an indication of treatment. I think we need to be very clear about this. That just the presence of diabetes alone is not treatment. I would go with the same recommendations that Dr. Rajvi so elegantly did in his talk. and use just those recommendations and follow the patient up. If there's increasing TSH, if the patient is symptomatic, these would be probably my reasons to start treatment. The most important thing, and I think in India this is even more important, is to repeat the lab. Because often the patient would come with a TSH of 4.5 or 4.7 and you know, be very worried, and all you have to do is repeat the lab and the TSH actually will come back to normal in a better lab. So I would just add that little caveat to this also.
Sujay, I just want to ask you, patients on insulin therapy and hypothyroid, do you think that there should be some kind of a slowness and escalation or intensification of doses, because the chances of hypoglycemia may be higher in patients who are not adequately controlled and you're trying to intensify control of diabetes, particularly patients who have not got adequate control of their hypothyroidism? So what is your take on that?
Well, I wouldn't be treating them any differently from people who are not on insulin or people who are poorly controlled or who are well controlled. My approach would be the same. In terms of management of the hypothyroidism per se, there might be differences in someone who's got ischemic heart disease or someone who's elderly. I would start low, go slow, gradually build up. But the mere fact that somebody's poorly controlled or somebody's on insulin or somebody's on sulfonylurea would not change my guideline. In fact, there are now studies like our honorable speaker mentioned that even in patients with acute myocardial infarction or following thereafter, you would be treating, except that where there's someone who's got angina, maybe you probably go slow. We wouldn't be treating any differently. Just one comment about the previous question about pregnancy. I think we've all realized that the 2017 ATA guideline is very different from the 2011 ATA guideline. When people talked about TSH cutoffs of 2.5 in pregnancy, the 2017 guideline talks about cutoffs of 4, and more importantly, your local regional data. Now, if you look at the several studies published from India in recent times, we are now quite sure that even in India, the TSH cutoffs would probably be somewhere between 4 to 5, depending on which study you're quoting, whether it's Dr. Rajesh Rajput's study from the north, our study from the east, and maybe even Dr. Shailesh Pitale's group study from Maharashtra, which is more of west, that maybe the normal upper range of TSH in pregnancy, at least in the first trimester in India, is anywhere around 4 to 4.5. And anyone having TSH greater than that, 2 until 10, that's the gray area that we are all worried about and concerned about what to do in that scenario. I think still I would probably be giving the benefit of doubt and treating between 4.5 and 10.
Okay. Dr. Salman, it's always sort of a bit of a concern that patients who have got reduced ejection fraction, and they may be symptomatic, they may be asymptomatic. Would you sort of slow down in terms of increasing your thyroid correction?
So I'm assuming you refer to people with subclinical hypothyroidism with heart failure with
subclinical or overt. Subclinical or overt. So whenever you're sort of dose escalating, would you sort of go at a lower dose strengths and see the response? And the next question would also be that how frequently or at what space intervals would you sort of do a dose corrections for these people?
So I think if somebody does have reduced ejection fraction due to untreated ischemic heart disease, I would be slightly concerned with going full dose levothyroxine and would want to increase gradually because of the risk of precipitating an acute event. On the other hand, if somebody has had an MI and has had their blockages treated either with a stent or with whatever the interventional cardiologist might have done, then I would be less worried about a higher dose of levothyroxine. The reason why I say that is that we do know from several studies that thyroid hormone levels have a positive inotropic effect. And if there is subclinical hypothyroidism in that scenario, there is a chance that it will have a beneficial impact on the left ventricular ejection fraction. And in fact, there are 2 or 3 randomized controlled trials that show exactly that, either with cardiac MR or whether with echocardiogram. So I think it depends to a large extent on other factors as well, the underlying cause for their heart failure, to what extent has it been treated, the age of the person, and so on. But generally, I would say there is more gain to be had in treating these patients than not.
Okay. And would you sort of keep your cutoffs different for people with with hypothyroidism, as to what would your cutoffs be for adequate control when you're treating patients with left ventricular low left ventricular ejection fraction?
Not necessarily. I think I would probably treat them to get the TSH within the reference range.
Okay. A last question to Rakesh would be, there's always a thing that, how frequently should you really be checking the thyroid function in normal as well as in patients who are on treatment? Because, people do right from no testing to very frequent testing. So what would be your recommendation in diabetics as well as in non-diabetics, normal and hypothyroid patients, both all these classes?
Yeah, so I think the stand of RSSDI was just mentioned by Professor Krishna Sheshadri and Professor Sujay Ghosh have just mentioned that, and we have clearly said that we need to screen all patients with type 1 diabetes at onset and every year thereafter. Type 2 diabetes, there's no clear consensus, but there's no, there's no strong evidence to suggest that we should screen them frequently, but it is clearly seen that patients with type 2 diabetes who have other comorbidities and who are who have family history, who have a quite probably they need to be screened, and the repeat screening can be done every 5 years. But now coming to patients who are on treatment with thyroxine, we need to sort of initially screen them, say after 3 months of initiating therapy to adjust the therapy and to get them to the target TSH level. Once we are at the target TSH level, then we need to screen only, say, semi-annually, that is every 6 months or 1 year would be appropriate to, depending on their accessibility to the healthcare, and that would be the recommendation to follow them up.
Thank you very much. Yeah, sorry, go ahead. You wanted to say something additional?
Yeah, no, I just wanted to conclude. Yeah.
Okay, thank you so much. I think we've run out of time. We are way over time. And I'm still getting a lot of questions, but I think we'll have to call it off now. And I would like to hand the mic back to Dr. Srinivas Murthy for his conclusion. Thank you very much, all the speakers. I think you've done a fabulous job. Very scientific discussions, and I think a lot of takeaway messages from this entire program. So over to you, Srinivas. And I'd also like to thank Abbott for the contribution.
Thank you, sir. I completely agree. I think we had one of the best science discussions now on thyroid and the latest updates. And I sincerely thank, it's my pleasant job now to thank each one of you, especially Dr. Salman Razvi, who's joined us from UK, Newcastle. Thank you very much, sir, on behalf of API and RSSDI as well. And I sincerely thank Dr. Sanjay Agarwal, our Secretary of RSSDI, for moderating very interestingly and also stopping overtime. So it's not overcorrection of thyroid. He stopped it at the right time. The correction was at the right intervention. And I sincerely thank Professor Rakesh Sai, Professor Sujay Ghosh, and Dr. Krishna Sheshadri for contributing and sparing their valuable time with us and enlightening our colleagues about the thyroid and the recent updates as per our RSSDA guidelines. And also, I sincerely thank Dr. Arul Raj, our President API, and Dr. Mangesh, the Secretary API, and Professor Shashank Joshi, Dean of ICP, and our chief guest today, Dr. Dilip, who's the Vice Chancellor of Maharashtra Health University, for joining us and giving us his pearls of wisdom. And above all, I thank Abbott India and their team, especially Swati, and led by Dr. Jyotish, with their unrestricted educational grant for API DIAS. And today we had a 28 successful API DIAS, and we hope to see many more of such enlightening API DIAS programs in near future. Over to you, Jyotish, and thank you for the opportunity. Thanks again, everyone. Stay safe and good night. Over to Jyotish.
Before Jyotish take over, somebody's going to thank you also. You did an incredible job with the entire program. So, I mean, this program was very lively and you did a fantastic job moderating the whole program. Thank you very much, Srinivas, for being part of it. Yeah.
Thank you.
Over to you, Jyotish.
Couldn't agree more to you, Dr. Sanjay Agarwal. I would like to start from Dr. Srinivas Murthy. So yesterday we were having some chat. So that both of Dr. Srinivas Murthy and I was talking. So I was talking to him. You are the best guy to do it, and I think the entire audience, along with the entire faculty, will definitely agree to it. My fact, who could have done it better than you? Thank you so much, Dr. Murthy. I would like to start with it from President Dr. S. Arul Raj for giving us this opportunity to collaborate on an API DIAS platform, an initiative from Associations of Physicians of India. I would also like to thank my close brother, Dr. Shashank Joshi, Dr. Mangesh Tiwaskar, the astute Secretary General of Associations of Physicians of India, for giving us this opportunity. Would like to also thank today's chief guest, Dr. Dilip Maheshekar, who is the Vice Chancellor of Maharashtra University of Health Sciences, for really sparing the precious time and for his chief guest address. I know that he had a word with me during the time that he has 2 meetings going on and he was in a conversation with Governor of Maharashtra, in between which he has really stepped out of it for some time to address us. Thank you so much, sir. I would also like to thank our international speaker today, Dr. Razvi, who joins us from US, basically Newcastle University from UK, to address the audience over here and really sparing his time to spread the pulse of wisdom. A special thanks to Dr. Bansi Sabu, the president of the Research Society for Study of Diabetes in India, for setting the context and giving us this opportunity to collaborate on this platform. Dr. Sanjay Agarwal, a man who has steered the program and the panel discussions, and they did all the discussions so well. Thank you so much, Dr. Agarwal, and thank you on behalf of Abbott for giving us this opportunity to collaborate with RSSDI for this educational initiative and for the guidelines on thyroid disorders. A special thanks to all the 3 faculties, Dr. Rakesh Sahai, Dr. Sujay Kush, and Dr. Krishna Sesadri, for their wonderful pulse of wisdom about the entire gamut of plan for the good management of thyroid, including diabetes. Thank you so much to all the faculties. I would also like to thank the team from Abbott, started with Mr. Anil Joseph, who is the managing director of Abbott India Limited. My colleagues from sales and marketing team, Neeraj, who is the division head, Preeti, marketing head, and my entire medical team, Dyotana, as well as Pawan and Somya, for doing the coordinations with all the faculties. Thank you so much. I would also like to thank the backend team headed by Swati Iyer for doing the logistic coordinations very well. A special thanks to all the delegates for attending this program. Please, as Dr. L. Srinivas Murthy has said, please do register because this program has been given 1 credit point by Maharashtra Medical Council. A special thanks to Dr. Ragam Bora, who is the MMC observer today. And I would like to request all of you to tune us again for tomorrow on the program API DIAS, which will be focused on COPD and the role of nutrition. Till then, do tune us, your prime program, prime time, API DIAS. Thank you so much.
Thank you.
Thank you. Good night.